Hello, everyone. This is Paul Sorajja from Minneapolis, and I have the pleasure of welcoming you to tonight's CVI webinar on novel transcatheter therapy. Just a few introductory slides, and then I'll introduce our esteemed faculty. This is a CME accredited activity if you would like to claim credit with these educational goals and learning objectives. These are our faculty with disclosures as listed here. We have Dr. Généreux, Dr. McCabe, and Dr. Yakubov, in addition to me here. In terms of the disclosures, those are listed on the previous slides, and we also have a disclaimer regarding off-label use. And we'd like to thank Abbott, Medtronic, and Shockwave for sponsoring this activity. If you'd like to claim CME credit related to this activity or any other activity that can be viewed online, you can go to this link here. And please keep in mind our meeting, which is going to be back in Denver on July 18th to the 20th at the Hyatt Regency. We have lots of opportunities for people to be involved, including travel grants for many people, challenging case competitions, etc. This is a very interactive meeting, and we'll look forward to having you there. So for this webinar, which will be archived at this website, you can also find this and others there for your viewing pleasure. And with that, I believe, is it going to be Jamie, you first? Is that right? Is that what we decided? Or is it Philippe?
I think if alphabetical by last name, it was Philippe first.
Okay, Philippe, it is you.
I don't want to keep him waiting.
Well, I'd like to welcome Dr. Philippe Généreux, needs no introduction. And Philippe, you want to start with your case and we can have a discussion. Do you want us to talk during your presentation or you want us to wait till you're done?
Absolutely. Please feel free to interrupt me. That must be difficult. That will be difficult, but please try. So first of all, thank you so much for the invitation. So I think we're going to start crescendo, decrescendo, crescendo, or whatever, this easiest to the hardest case. So this is a case maybe you may be able to do on a daily basis, but we use a special tool. So I'm pleased to present this case. So I work at the Ganglion Cardiovascular Institute at Morristown Medical Center. This man, we treated this guy, I think 6 months ago, 76 years old male, had a SAVR in 2012. He had Edwards Life Science valve, 2700 perimount, 23 millimeter. Had normal coronaries at the time of the SAVR in 2012. He came with shortness of breath. He's a avid softball player, and he ran fast and had issue to run now, could not play softball anymore. He was very sad about that. He has a multiple myeloma and under treatment, but that was well controlled. This is a coronary at the time of the SAVR 11 years ago, were pretty pristine. And this is when he came to see us. As you can see, he does have severe restrictive aortic stenosis on the bioprosthetic valve. And there's no doubt about that. So obviously, 76 years old, the debate was about reduced surgery versus valve and valve. Always do a CT scan to help with this dilemma. So you can see he has loopy vessel, but nothing prohibitive for a TAVR procedure. Great aorta also. And then we undergo a deep CT analysis, as you can see. Always important to remeasure the valve. We never assume anything. And this is the annulus level. This is a sinus, so kind of generous sinus, 34, 34, 34. This is the STJ, and a large STJ also. LVUT, no adverse feature. And the ascending aorta, a little generous, but nothing surgical by itself. One of the most important thing, the height of the STJ. Here you can see around 14 on the left and the right 15, 16. The coronary heights were pretty low, but that's not the most important metrics. You can see the left coronary was 5.7. The right was around 8. But the sinus were kind of generous. And this is now where we go to the VTC. The distance from the frame from the ostium to the coronary. You can see for the left was 5.1 and the right was 4.3. So not really under the cutoff of 4, so but kind of borderline. And I think that's important for the discussion, what we consider at risk for obstruction, but also for coronary access in the future on an active 76 years old man. And this is the VTS at the height of the STJ. So the distance from the expanded valve to the STJ, you can see on the left is 3. Iris is considered less than 2, so 3 is borderline, but not super high risk. And the same thing on the right was 4. So I'm gonna skip this slide, and then we're gonna go here to the coronary by CT. We're fine, so we didn't feel the need to recap the patient. He had normal cath, so normal coronary by CT. So maybe we can discuss here briefly. So for us, SAVR versus TAVR, both were very doable, as a matter of fact. Very nice patient for surgery, but he completely declined. He also had myeloma, and he felt that he didn't want to go through or redo surgery. He didn't have his experience the first time. In terms of risk for coronary, were borderline. The height is borderline. The VTC is around 4 and the VTS 2, especially on the left side. So the thought was really this is a young patient, potentially we're going to need PCI in the future, or at least coronary access. So we decided to enroll in this shortcut study to split both leaflet. So I'm going to stop here, and maybe Jamie, you have experience with those type of case, and maybe what are your thoughts, your first impression?
Well, I mean, first off, I don't think you need to kind of make a strong argument around valve TAVR. A 76-year-old man, he's already had a surgery. We wouldn't have even really engaged in a conversation about a redo surgery, if I'm being perfectly frank. I think it makes all the sense in the world to go with the valve and valve. I mean, arguably a 23 paramount in a man at 76 who's pretty active is kind of a smaller size valve. And I think that the coronary risk in this scenario is, in my mind anyway, potentially related to the opportunity to fracture the valve. If you wanted to make the valve a little bigger, you wanted to get a bigger ID for your next valve, then the VTC and the VTSTJ need to accommodate that, right? I mean, that adds a layer of unpredictability, because obviously you don't know exactly how big the valve gets. You know how big a balloon you want to fracture with, but whether there's recoil, etc., like, it becomes a little confusing. So I think as the complexity of coronary protection goes down, our willingness to use it is going to go up for obvious reasons, presuming that it's safe, and particularly if it affords you the opportunity to try and get a bigger ID in an active 76-year-old person.
Well, that's great comments, and I share your point of view. So clearly, valve and valve was probably the best option, the most appropriate option for him, and we elect to enroll for the exact same reason. The patient was borderline. We could have done this case with no protection, but the retreatment in the future for us was the biggest risk. So we want to make sure that we have an easy redo TAVR valve and valve in the future if ever we have to go there.
Can I just ask, I mean, Steve, what do you think about this case and the need for shortcut? I just want to make sure we have a good understanding as to why we're doing it. Is there even a remote possibility that you would just do valve and valve without any leaflet modification?
Yeah, so most centers don't have the availability for shortcuts, so it's either doing basilica of the left system. It's unusual for people to do basilica of both the right and the left leaflets. And I think in this particular case, I don't think you're at particular risk of coronary occlusion. I think your VTCs are adequate. Your distance around the STJ is adequate, and you could put a sapien valve in. You could put a core valve in here, and I think you'll be fine anyway. And I would believe that the vast majority of centers would do valve and valve, and probably do no protecting of the coronary arteries, and they would not do leaflet modification. Having said that, 5 years from now, I'm hoping we do leaflet modification in every case, because I think it will be even better. So it's important for the studies to be done, and I think this is a great case, Philippe, and I can't wait to see what you show.
Yeah. And I think exactly. So this, you can get away with this case on a routinely basis. I think the concept here is, can we reaccess the coronary in the future? And if it's easy, like Jamie says, if it's easy, reproducible, why not doing it? So
So can I just ask one more question, Philippe? Sorry,
Yep,
you said I could interrupt. You said I could interrupt you.
Yeah.
And does the potential for BVF make a difference? And how does that influence the need to do shortcut versus not doing it?
You know, the typical criteria 4 and 2 for VTC VTS never really take into account valve fracture, but I strongly believe, to have been on the wrong end of one cases, I strongly believe that that should be taken into account, and we should have more permissive criteria, I will say. Not that the area or of any you know, in a prescriptive by any means, but that's the reason why we enroll the patient, because it's borderline, he's a young guy, he's very active, and we may have to fracture. You're gonna see.
Does your threshold for VTC change? Like, how do you take into account what should be the VTC minimum if you're going to do BVF? I mean, I tend to think of 3 if I'm not doing BVF, but what is it with BVF? Does it change at all?
I don't know. For me, my mind, 4 is the cutoff, but Jamie, what do you think?
Jamie, Steve?
Well, you know, you can obviously, your VTC is defined in accordance with whatever size hypothetical circle you put into the program, right? I mean, you could you can make the VTC anything you want based on how big the next hypothetical diameter circle is, or valve is in the CT scan. So if you set the if you define the VTC based on the size of the balloon you use, right? Like, let's say, you know, you've got well, I mean, it obviously gets complicated, right? Because if you're doing a sapien in this case, and you're not going to valve fracture, it's not going to fully expand, but we put a 23 millimeter circle in there anyway, and then you define your VTC based on that, right? And that's probably an exaggeration of the or kind of a worst case scenario VTC, because you know you're not going to get full valve expansion. But you can define, you know, you can change the parameters of that circle to try and reflect what you think you're going to get with balloon valve fracture, of course. Just really complex to know, because obviously you can't incorporate post deflection, right? I mean, if you get less fracture and more just dilation of the posts, which will splay the leaflets, how do you incorporate that is obviously incredibly complicated. You know, these aren't volumetric assessments, they're 2-dimensional things in a volumetric or 3-dimensional scenario. So I mean, we're playing in a very rudimentary space right now.
Yeah. All right.
All right, Steve, any comment? You good?
Yeah, that's a great question, Paul. I don't think we have any idea to accurately model what BVF will do to the VTC in a surgical valve. So I think you use the VTC that you have, and you may say that it's going to change, but I don't think it'll change more than 1 millimeter. And I think if you're 4, you're definitely safe. If you're 3, it's maybe a little questionable, but I don't know where that's going to be modified. So we don't really model the BVF when we do this.
Yeah, great.
All right, so we enroll in Shortcut, and just for the people that don't know, actually, Shortcut is a dedicated splitting device. So 2 element, an arm and a little blade that's going to come up and hit the element in the back. So it's really like a miter clip. You try to clip the leaflet, you put your arm in the right place. You can help yourself with a coronary. T is also useful, and then you just deploy the blade and you retract and you split. And you can do the left or the right, you can do dual split. And it's the good thing about it is it's like a TAVR. It's 16 French compatible. Feel like a core valve. You need to use a wire, and you place it and you turn the element, the kind of the arm, and you just put it in a sinus, and that's it. So as you can see, it's pretty simple and intuitive. The FDA mandate that we just try to split the leaflet once attempt per leaflet, which can elevate the bar. It's like fighting with one hand in your back, but it's still it's very reproducible, and it's not complicated. And for MitraClip operator, it's pretty simple.
Philippe, would you prefer to split it, the leaflets more than once?
Absolutely. I think,
Okay.
I mean, in my experience, there was like probably 80 cases worldwide done. And most of the case, I mean, all the cases have been with one attempt. But once this thing before it become available, I mean, I will, if the split is not satisfactory, I may split again. That being said, we have to be careful not to lacerate this leaflet and become like a kind of a weapon, and you may occlude or. So I think to split in the middle of the leaflet, just actually in front of the coronary, not always in the middle of the leaflet, but in front of the coronary is the key. And you really go to the base. So maybe you want to try to grab the base more, but yeah. So this is the way it works. So you start with one leaflet here. We start with the right. Again, bring this element. There's view, actually. There's a front view and a side view. Usually you start with the front view to localize actually the middle of the leaflet. Obviously, there's TTE that can help, but really fluoroscopic guidance. You go in the middle of the valve. And then you like to go on a side view to see the element, the blade exiting. Not mandatory, but it's nice to see the blade, and you can also have a feeling that you grab the leaflet. And then we did the right, and then we just turned and did the left. Okay, so the right took maybe 10 minutes, and then 5 more minutes for the left. So in 15 minutes, we split both. And you can see there's when you grab the leaflet, you have gentle retraction of the catheter. Right? To be quite honest, I did 3 cases in US, 1 in Europe, and 2 out of 4 cases I did. I just pushed the wire and the leaflet just split by itself. So it's very gentle, and you feel the heartbeat. You don't have to yank it. You really just have to push a little bit the wire and pull a little bit. The second version will be like a rotoblader. You're just going to have to move the element without playing with the wires, which is pretty nice. This is the confirmation by TE. You can see there's literally a disruption of the right and disruption of the left. There's no doubt here. And the AI really increased significantly. It was, almost none at the beginning, and become mild to moderate after the right, and the left after that becomes severe. Patient was stable all during the entire procedure. This is after 2 split. Can see there's definitely a therapeutic effect here. And then we just did it a regular TAVR. We use S323 here. Could have used a core valve, and the case went well. We didn't have to fracture. Go to the next slide. The gradient was 7. The mean gradient was 7 right after the procedure. Is the splitting the leaflet help for the valve hemodynamic? Who knows? I like to think so, but this case was a great case. At 30 days, the gradient as usual were like 16, 15, 16, but the guy feels amazing and is great. So, so I think just to summarize and maybe for discussion, I think leaflet modification is the future. There's no doubt for TAVR and SAVR, TAV and TAV, TAV and TAV and TAV, or TAV and TAV and SAVR, and also for the native. Okay, so obviously the next step is to split the bicuspid next to the raphe, make them tricuspid, make the valve more central, more circular, yes, more expanded, but more central, not marginalized on one cusp or the other, and really to ensure repeatability of the procedure. I love shortcut. I think there's other devices that will also succeed, but I'm not a Jamie McCabe of the field. I'm a average Joe who use shortcut, and 4 of my cases I split twice double leaflet, so very easily in 15 minutes. So I think that the ease of use, like Jamie said, is the key. But I'm sure other tool will be able to succeed, and I think the percutaneous leaflet modification is the future, whatever is the electrosurgery, mechanical cutting, but also removal. I'm very excited to remove leaflet. To what extent it's going to be possible, safe, or always needed, I don't know, but clearly this is where we're going.
Philippe, can I ask you a couple of questions? What is it done from the contralateral groin, and what size is it? What French size?
So it's 16 French, and you use on the same side of the TAVR. So
Do you ever get profound aortic insufficiency that's trouble before you
No.
have a chance to deploy the valve? And then do you use it with embolic protection?
Yeah, so good question. So all the case, I think there's 80 cases worldwide that have been done, compassionate use study. All of them have been used with embolic protection. When we look at the compassionate use, because I can't comment with a study, but there's the basket. In the basket, we're sent to renew Germany, all the basket, and nothing different in the TAVR, okay? No stroke in the 8 patient. We're going to have the result of the shortcut study at EuroPCR as a simultaneous publication, most likely. So obviously it's pleasing to use this, but I'm not sure it's needed, to be quite honest. But I will do it, because depending on the valve, I think that could be dangerous. None of those cases needed were unstable. All the cases in the experience so far, and it's pretty well tolerated, because again, it's on the same wire. So let's say you put a 16 French sheet, whatever the brand you like, you do your thing, and then you remove this on the same wire, and then you put the valve right away. So the valve is ready. So there's no big issue. So yeah, so
I think this is incredibly exciting when I think about the pain pinch points of basilica and such. This is incredibly exciting. Is there a leaflet thickness or calcification amount that is a cutoff that doesn't allow you to do this, Philippe?
Yeah, so there's 4 millimeter that has been discussed, but because of the bench testing, I think Paracardia has an amazing database of more than 1,000 valve and from surgery, but the new device where you can almost seesaw, I think that will change. So and most of the time the blade will go around the calcium. I was talking about bicuspid. I mean, you just need to go next to the ref. You don't go where the calcium is, you go next to it. But I think the challenge would be the excessive calcified valve. This is where there's another tool called Leaflex, where you can crack. Maybe you do a little bit of cracking in the valve, then you split. Who knows? I think we enter a field of like leaflet modification and whatever the type, splitting, cracking, shockwave. Who knows? But I think that's the future.
Well, surgeons always cut out the leaflets when they do their SAVRs. So you got to think that this is an important thing to consider. So we'll move on in the interest of time, Philippe. That was great. Jamie, I think you're up next. You might be muted if you are.
All right, there we go. Oh, can you see my screen?
Yep.
Great.
Yep.
Well, that was a cool case, and that is a cool technology. So I agree with Philippe. That area is going to rapidly evolve. I really am pro leaflet removal, and I look forward to the day when we don't have to justify it. We're just like, we're going to put it in a TAVR, we're going to take the native leaflets out, just like surgeons do, right? Because that would be just wonderful. All right, I wanted to show, so I'm Jamie McCabe. I work at the University of Washington in Seattle. I wanted to just show a case that it was just an uncommon valve and kind of flummoxed me a little bit. There's no real sexy part to this other than sort of trying to get everyone's opinion about how they want to approach this. I've seen 2 of these now, but this is the first one I ever saw. So it's my disclosures. So it's an 82-year-old male who showed up to an outside hospital that we partner with. It's syncope, or maybe he had arrest. It was a little unclear, but ended up being in complete heart block with some evidence of end organ dysfunction. He got a pacemaker. His lactate improved. His creatinine was kind of slowly coming back to normal. But then in that context, he got an echo demonstrating an aortic velocity of 5.2 and a mean gradient of 70, and some AR. And digging into this history that was very sort of hard. He didn't have a card in his wallet or anything like that. He just said, oh, I had an aortic valve in 2005. and a 2-vessel bypass. And it had never really been, he sort of got lost to follow-up, essentially. And after kind of hunting through records, we found that he had a shell-high valve, a stentless valve. And we actually figured this out after his CT scan demonstrated these remarkable looking, they almost look like lily pads to me, but they're like they're the sewing tabs. They sew on above the STJ to the aorta. So they're sewn to the wall, like sideways, as sort of the commissural areas. And it's otherwise a stentless valve, but very bit of a hard valve to work with, or maybe at least just for me, a hard valve to work with, which is why I wanted to share this in case it comes up. I mean, I guess all stentless valves are a little bit harder in general, but anyway, so let's look at the CT scan, and then I want to get everyone's opinion on what to do. So as was mentioned, I think confirmation, it was supposed to be a 25 shell high, but confirmation of sizing with CT is always important. This is the annulus just below the valve, a mean diameter of 18, area of 255. This is supposed to be at the annulus, 21 by 24, area 411. LVOT sort of further down, 403, 20 by 26. And then if I can keep going here, here's just sort of a gross 3-dimensional view of it, giving you a sense that there's just a lot of LVOT calcium, sinus calcium, STJ calcium, coronary like, the tissue planes were relatively confusing. Not the most effaced sinuses you've ever seen, but not bulbous sinuses either. And then when we look at coronaries, it's a little hard to say where exactly the annular plane is. We sort of picked this, but oops, sorry, I skipped ahead. And so this would give you a left coronary height of 14 with a leaflet height of 17. I don't know. I mean, on this one, if you pick a different plane, you get a left coronary height of 8.2 to the base and 14 to the top of the leaflet. With a VTC of 3.7. And then if we go to the right, here, coronary height 16, leaflet height 12, kind of a secondary measure 10, maybe. VTC smaller at 2. We didn't even do VTSTJ, I don't think, on this one. He had coronary unlimited angiograms. I didn't put up coronaries are patent. There was no backwards flow into this sort of supposed Lima and supposed SVG. We couldn't find any competitive flow, backwards flow. We didn't really go hunting for it because he still had creatinine still around 2. So we took like 3 pictures and called it good. So I'm sorry I didn't pull those up for you. So with that info, and I don't think I showed you the sinuses diameters, did I? They were, I'm sorry, I did not. I want to, well, you can kind of get a sense off the VTC here, right? That the right sinus is not much. There's, some sinus, but not a lot. And these are the, I believe anyway, this is kind of the calcification of these stentless commissures on the sides, though it's a little hard to know. It's going to get even harder to know on fluoroscopy, if that makes you feel any better. So anyone have any thoughts on how they want to approach this? I'll obviously share what I did, but there's probably a lot of room for people to do it better.
What is the size of your circle that you put in your VTC?
This one is a 23.
Okay, yeah.
Hey, Jamie, I know there's a patent Lehman, a patent vein. Where's the vein going to?
No, they don't seem to be patent at all. We got
they aren't.
No competitive flow in the LAD territory. In the left-sided territories, we saw no competitive flow.
Okay, and then that first area measurement that you had, was that above the annular plane? I mean, this is a very funny looking valve at a very funny looking CT scan. Is that above your?
No, this is just below. And you know, like most stentless valves, the sewing cuff is actually kind of below the nadir of the leaflets.
Yeah.
And so it's just sort of below the nadir of the leaflets, which is usually the smallest diameter in a stentless valve. This is kind of at the nadir of the leaflets, and then this is in the true, native LVOT.
Maybe I can propose what I will do. It looked like a freestyle. I think one of the first
Yeah.
valve ideas, a freestyle in
Yeah.
19, and I was young and innocent. I think it's in 2016, and I just slammed a S323 in there, and it looks so underexpanded. She was a teacher, and she lived a long life after that, and it worked well, but it looked terrifying.
Yes.
But I think in the future, if you have shortcut or whatever, you double split this thing and protect with water both side. And because you split, you're probably going to be able to stand if you need to stand, like flush and optimal, no snorkel. But I think for me, I will shortcut those two or split those two and put S323 with protection of the wire. But that's a big project if you don't have a shortcut. But I think that would be the plan. But
So Philippe, if you don't have shortcut, are you talking double basilica here?
yeah, so double basilica, it's not done frequently. I think that's because it's so cumbersome. But I trust Jimmy.
Well, I'll freely tell you, I hate double basilica. I mean, nobody likes doing a right coronary basilica. That's not a real thing. I did the case just before coming on here was a right coronary basilica with Telltale, actually, which was really pleasant. Just having the dedicated catheter with the anterior sort of anterior bend on it. I otherwise am pulling out a heat gun or using a steerable guide, telescoping, but. My feeling was that the left was more jeopardized, even though the VTC was a little bit wider, just because the coronary seemed lower and the leaflet seemed longer. I just wasn't really sure. Whereas on the right, this leaflet seemed shorter. This kind of seems farther away for whatever you want to make of that. That was how my interpretation of it was that the left was needed more love than the right. I don't know, Steve, what do you think?
I think that's a great plan. I think you should basilica the left and try to get this case done. But I think landing the valve and making sure that it doesn't move on you is a little bit tricky in this case.
Yeah.
That very narrow area that the bottom of the valve is, sometimes you don't know how your valve's going to react on there.
Yeah.
I hope this valve is visible in fluoro.
No, stentless valve. Let's get right to it. This is what it looks like on Fluoro.
Yeah.
And I wanted, yeah. So I mean, the tissue planes just made no sense. The nadir was really difficult. Obviously, it looks like I've got right non-overlap here a little bit. And then you got this thing over here. Just want to draw your attention to that for a second. Like, what is that? It looks like it's coming off the left. It looks like it's coming off the left. I was like, what is that? I can't understand what it is. Oh yeah, I put an arrow to it. Like I don't know what that thing is. Can you have a paravalvular leak of a stentless valve? Like, is that even a thing? I don't know. So
So Jamie, can you talk a little bit about your fluoroscopic markers for basilica here? Because you don't have little circles on the stents or commissures. I mean, how are you knowing where you are supposed to be?
Well, on the left side, it's usually the sort of cheat view, the side view, or whatever you want to call this view, where the coronary's here and your AL2 or 3 typically is here, is kind of an easy view to get for the left. It's usually a little bit LAO. It's the en-face view that's more complicated to get in these pictures. But in particular, I want to show you that a little bit. So here I was like, we're obviously trying to use TE to figure out if we're in the left cusp primarily, and then some contrast. But keep in mind his kidneys aren't great, so I don't want to use a lot of contrast. And with the AR, it becomes more complicated. But I thought I was okay but then it looks like there's another sinus out here, right? That do you guys see that? It looks like I'm in a sinus here, but maybe there's another sinus there. And so I was like,
Yep.
maybe I'm in the right, and it's just like there's enough kind of blowback that it's going to the left, and we're trying to figure out what TE is a little. So I said, okay, I'm going to pull back and I'm going to clock a little bit. I'm going to try and get over to the left here, and then I get to here, and now I mean, what is I like? Come on, what is this thing?
That looks like a PVL.
Doesn't it, of a stentless valve, which
Yeah.
I don't understand these tissue planes. I don't understand how that's a thing, to be perfectly frank. But it does seem like it's a PVL. It's going into the LV, and it's right in front of the left main, obviously. So that I I don't know what it was, but I was like, well, I guess whatever it is, we're gonna plug it. So I put an AVP4 in it, which was, we already had the catheter there that you can just put a 035 microcatheter through that and then drop an AVP4, and that's pretty straightforward. So we plugged that and then decided that obviously wasn't where we wanted to lacerate. And then tried to reconnoiter our catheter to someplace valuable. And now we've got this, and I was like, well, that's still the plug. The plug is thrombosed already, so that's nice. And then, but you're like, what is this tombstone? I don't, it's just like, for the life of me, I was like, I just don't understand what I'm looking at half the time. So in the end, we went back to the same spot that we were in before. I put some dye in it for you because it does look like it's filling the left, and on TE, it seemed like that was the left cusp. I should have grabbed the TE. And so that is where we punctured here. And so there's our puncture. And then ultimately basilica, which was smooth. No, nothing. Once we sort of figured out roughly where we thought we should be, wherever we were, we cut it. And that went, along relatively easily.
Jamie, was it pretty easy to determine that you are not outside the valve? That you were actually on the leaflets on the echo? I think that's quite a challenge here with these stentless.
That's a really good point you bring up, and a really good teaching point is we always do. There was a time when I got a little cavalier with basilica and started doing it just fluoro based, because half the time with a lot of calcium in there or with the valve in there, the imager will tell you they can't tell if the wire is in the LVOT and the blah blah blah. But the one place they can tell you where the wire is the left atrium, and it is remarkable how easy it is to go from the left sinus into the left atrium, despite going straight down, and for all the world looking like you're exactly where you should be. And having made that mistake rather dramatically at one point, I am really adamant about doing these cases with TE. And once we puncture through the leaflet into the LVOT where we think we're in the right place, we do a dedicated sweep of the left atrium, because the 014 wire is very visible in the left atrium, if it is there. And so we do double check that. Now, and I wish I had always, for a different day. So, and then we went to a 23, and now, and I guess to Philippe's point about whether or not this was the right valve, or should we have used a self-expanding valve, you'll see that, just like stentless valves, we try and deploy a little bit low, but get a decidedly underexpanded valve. And so maybe if I were going to do this again, perhaps it would be a self-expanding valve, or maybe an X4 or something. But that 23 is wacky looking.
Hey, Jamie, is it wacky looking because of that thing over there near the left cusp?
Well, yeah, that plug is still there. That is true. And it's not really clear that we don't even really crush that at all. Do you see that? Like, I wasn't sure if I needed to plug that, because I thought maybe I would just obliterate that space, but we don't. That doesn't move even a little bit.
Looks like
you've got a boulder there.
I know, it
mean,
looks
that's
like it's
really-
crushing you rather
Yeah.
than you crushing it.
I often am the loser. Yeah. So that was how we left it. Not, wasn't that it obviously flared in the LVOT just like the CT suggested it would, but wildly underexpanded. Here are the hemodynamic gradients. So we got, as is often the case on direct hemodynamic measurement, it looks quite good. Oops. And then on post-op day 1, 2.8 meters per second, mean gradient of 19 and a DVI of 0.4. So some evidence of PPM, obviously. But he came from further afield and has not returned. So I just did a little search through our records and couldn't find anything recently. So I can't give you an update, but it's been about a year. And as far as I know, things are going okay.
He's got his left coronary.
And he's got his left coronary.
Jamie, how do you decide if your basilica is adequate? Do you look on TEE? How do you
Yeah.
know that you got it right down the spot you wanted, or if can you
mean
always
the-
see it on TEE?
The puncture spot?
Yeah, the split.
Oh,
we
the
always
split.
say we see it, but
Yeah.
sometimes I feel like we're imagining things, where
Well,
we want it.
I think that on tip to base lampoon, you don't always know if you've cut something because it's a pull type slice, right? Which is sort of similar to a shortcut, that it's not guaranteed that just moving cuts things necessarily. When you puncture through the leaflet, and then snare it, if the wire has come out of the body, you've cut the leaflet by definition, right? Because you started at the base of the leaflet and came to the tip of it. So now whether or not you started basal enough or just had a quote unquote tip split, or whether you were kind of askew from the ostium of the coronary, I think those are all very reasonable questions and ones that you'd like to figure out before you do the cut. Obviously, you'd prefer to sort that out at the time of puncture preparation, so that you're not fenestrating in multiple spots. And that can be hard, for sure. But once you get to the point of once you get to this point over here, there is no world in which pulling this back doesn't cut the leaflet, right?
So Jamie, I have a quick question for you.
Yeah.
So we see more and more coming TAVR failure. I mean,
Yeah.
before, last year or 2 years ago, I didn't see a lot of TAVR failure. I didn't do the TAV and TAV. Now I think I do one a week.
Wow.
TAV and TAV.
Yeah.
And then it's coming, is growing,
Yeah.
they're all
Yeah.
coming back. And before I came at Morristown, they were doing a lot of core valves, so now we're dealing with a lot of TAV and core valve.
Mhm.
So lacerating, your experience with basilica or splitting of TAVR valve, it's going to be
Yeah.
different with the interaction with the frame. And are you afraid to pull the valve out, or what is your thinking? Or Steve?
My sense is that it is basilica specifically is procedurally easier in TAV because you have an upper cylinder, so your catheter is always inside the valve, right? Unless you have one of the very unlucky scenarios where you somehow are able to kind of fish through some open cells of the evolute and then kind of come back into the main kind of cylinder of the evolute, in which case you will have a wire wrap around a cell, which I've done once. But by and large, as opposed to a surgical valve where you can be on the sewing ring, or you could be outside the sewing ring in the sinus, you really can't do that with TAV. So that part is easier. That said, I think, there's a lot of conversation about whether or not a slice can adequately splay, given that there is a frame that constrains it from being overextended, which is really the mechanism by which a small slice becomes a V, is that you have to push the leaflet past the posts, right? And in an open cell structure, in a tube-like structure, doesn't really do that. So BA basilica is thought to be better. Balloon-assisted basilica is thought to be better for TAV and TAV, to try and get more basal splay to facilitate a splice. I don't really know. I think leaflet excision is really going to be the way there, but I'm not sure.
Hey, Jamie, there was a comment in the chat that they wanted to know if you saw your PVL on TE echo or just on angiography.
That's a great question. I don't remember.
Okay.
Great. Well, thank you, Jamie. We should move on here in the interest of time, and it was fantastic. Steve, you want to show your case? So Philippe, I hear we'll talk a little bit about leaflet modification. So there are rumors that there'll be a DRG that'll support some of these things that we've been seeing off-label and in development for these various companies. You think the reimbursement will meet the cost of these devices?
Yeah, so yeah, I think Patcardia is working very hard to obviously get a reimbursement. We have a strong case. We're gonna see in a few weeks, but we're all cautiously optimistic. Obviously, this is something that it's take time. It's not simple. I will say it's like, 266, 267 or whatever, which we should have 265, so which is, TAVR with leaflet modification. The same as we have rotablator or rotational atherectomy or orbital atherectomy. So I think that's finger crossed is going to happen, and I think that's going to a little bit legitimize the use and also reward us for the time spent, and maybe if something is easy to do, reproducible, better for the patient, I think that's great. I think that's that will expand the use. So I'm cautiously optimistic. So and I think hopefully it will be able to be applied to all the modification technique. If you do reflex or excision or etc. I mean, this is more time, more risk, more benefit. So and then the question will be, should you modify or not? The same as should you do a roto or not? So I think that's an exciting time. I think we do TAVR, but I think leaflet modification for me is the next 10 years of my career where we're going to debate, should we split, should you cut, should we electrify, or should we remove? So I think that's would be the planning of the case,
I mean, I certainly think it goes way beyond TAVR, right? I mean, it's TAVR, it's mitral. You can imagine now that we have repair and replacement in the United States for tricuspid, that leaflet modification there also would be considered. Jamie, what do you think? This is an important part of our future, huh?
Yeah, no doubt. I mean, we've spent 40 years not we three, but the field has spent 40 years refining how to put things into the body and spent 0 minutes figuring out how to take things out. That's going to change, right? I mean, we can't keep putting things in without ever expecting to take stuff out. Steve, you nailed it. That is great. You just need to flip to the presenter mode.
Well, historically, Jamie, whenever we've had to take things out, it's usually a snare to retrieve something we've lost inadvertently. But the thought of taking things out to benefit a patient intentionally is, I think, very charming. One more to the right. There you go. Perfect.
And now you're still on mute.
Here we go.
You did it.
I did it. All right. So I'm going to take us through a journey in a TMVR and ring case. So I just learned from Jamie how to do this 2 days ago. So I'm going to show you the case that we just did 2 months ago or a month ago. Okay. So here's the case. 60-year-old, very thin woman, severe shortness of breath, 3 previous sternotomy incisions. 2 surgical valves had been explanted from aortic surgeries. She has a current bioprosthesis. She had 2 mechanical valves sequentially placed in the aortic position and were removed, and then she has now a bioprosthesis. She had a mitral ring and repair with that last surgery, and this was 3 years ago. That was done for severe MR. She had radiation to the chest 8 years previous for breast cancer. She also received chemotherapy. Her ejection fraction was reduced to about 30% after the chemotherapy. It's recovered to about 50%. She's anemic with a hemoglobin 9.8, a little elevation of her LDH and stage 3 kidney disease. She was sent to us for consideration of valve and ring. So that's what our plan is. So I'm going to run you through the echoes. It's kind of a nasty looking valve. You could see that the ring is in place, lots of MR, lots of eccentric MR.
Steve, what kind of ring was this?
It's a semi-rigid ring. It was I can't remember the type of it, but it was it was a semi-rigid D-shaped ring.
Okay.
She has, so these are just the images that we received from the outside institution. You could see a lot of severe MR. This is about 3 months prior to our procedure. She saw our heart failure team make sure that she was optimally managed with medical therapy. So here's our plan. Bring her to the hybrid room, repeat the imaging, use a VersaCross transeptal device. We're going to do tip to base lampoon. We'll dilate the septum with a 12 millimeter balloon, use a Confida wire and a 23 or a 26S3 TAVR in the mitral position, and then pace off the wire. We typically would pace off the wire. I know some people aren't terribly fond of that. And so she comes to the hybrid room, and here are her images, lots of severe MR. And then my echocardiographer said, you got a little bit more of a problem than you thought. There's a paravalvular leak at on one of the images to start with. So that kind of explains her LDH elevation or persistent anemia that was undiscovered first. So does that change your plan at all, Jamie, or did you proceed as planned?
Yeah. Well, I think my feeling is that a small dehiscence, it looks like you might have a small medial dehiscence. And
Yep.
A small dehiscence is doable, but you should expect it to get bigger because when you put the sapien in and you reconfigure you circularize the ring, where it's dehisced, it often will get more dehisced. And now small ones, they may not, particularly if you're oversized enough in your com, it's often on the lateral, it's often medial or lateral. And if the com distance is 26, 27, where even with circularization, the sapien is going to smush everything into the sides, it may not be terrible. But if you have let's say a com distance of a 29 and you're putting in a 26, and you're going to sort of pull those sides in by pushing the AP distance out, you should expect that might get a little bit more. This doesn't look like a whole heck of a lot, and I think it's very reasonable to keep going. But if it was sort of big to start, I will sometimes throw a wire in the dehiscence before I get going and then do the valve so that if it gets worse, you have a wire is not through the cells of the sapien, and you can put a plug in a little more easily.
Paul, what have you done?
I would have just done the valve and ring with the lampoon as you planned, and then be prepared to close a PVL.
Yeah.
I agree with Jamie. I'm pretty confident that's going to get bigger. Just by the way it's stretching.
Yeah, that's exactly what we thought. This thing is going to get bigger when we're done. So here's our procedure, our tip to base lampoon. That was relatively easy, straightforward. And then here's our deployment of the valve. And like we've talked about before, that it's the one operator deployment technique where he's controlling the wire and pushing up on the sapien valve at the same time, the push on the wire, push on the valve to try to stand up the valve and get it exactly where you want it. And so we're pretty happy with the way that the valve deployed. And then here's our PVL, which did get bigger.
Yeah. Not horrible, though.
Yeah. But there's no way you would leave this, right? You plug it, right?
Yeah.
Yeah, but it's not like it's not like oh geez kind of
no
thing.
Yeah.
But we knew that this would be trouble, especially with her hemolysis. So then the real issue becomes, what's the size of the hole and what do you put in there?
Yeah.
I don't typically size.
the nice thing is that you've got, the Sapien in there with a huge frame that you won't have problems with leaflet impingement.
Yeah.
You can start stuffing plugs in there as big as you want,
Yeah.
and it should work. I suspect, looking at this, I would probably say 2.8s or 2.10s, side by side, maybe 2.12s, but
What's your
Yeah.
preferred type of plug for these?
I tend to like AVP2s, because early in the experience, we were putting in VSD devices and the mesh actually made hemolysis worse. And I've heard other people have similar experiences. So I like AVP2s. AVP4s also be great. But honestly, it's so big, I think anything would work.
Mhm.
What would you choose, Jamie?
I go back and forth and round. I agree that there's like some recency bias for me. I'm not smart enough to like have a great plan. I'm just like the last time that one was a pain in my bum. So I do use VSD occluders sometimes. I like the rigidity of them actually, against the frame of the Sapien. I like AVP2s.
Yeah.
I don't like ADO2s, which I used to use. They're too thin, they're too floppy, and I pull them through inadvertently.
Yeah.
I worry about those embolizing too. I just don't. Yeah.
I usually
Okay.
I don't spend that much time messing around with the glide wire if it doesn't go easily. I just throw coronary wires down.
Yeah.
That's just been a recent change. So we use the steerable sheath, a 5 French MP, and then the glide wire didn't go right away. So I threw a coronary wire, and I kind of like that better now, just because you could throw the coronary wire out the aorta and snare it. And that's the best. I think that's the best way of doing these, is that with that rail, you could really control putting any type of catheter, especially if it's difficult to get through the hole to start delivering devices. So that's what we did. We put the coronary wire out the aorta, snared it. Now we've got a great rail, put a 5 French Amplatz delivery sheath through there, and then tried to stay out of the frame of the Sapien valve on delivery. And this is an AVP2, this is a 12 AVP2, and put a lot of the distal disc into the tunnel of the PVL.
Mhm.
And the other nice thing about having a rail is you could really control your atrial sheath and smash the top of it down very well. Sometimes AVP2s are a little tough to push all the way down into the hole, but if you have a rail like this, you could really smash it down inside there. So that's just a demonstration of delivery of the device, and we were pretty happy with that. That's what it looks like on
Wow.
on echo.
Just one 12 mm
Yep.
AVP2, huh?
Yep.
That's
Close the whole
impressive.
thing.
Wow. And the great thing about the rail technique is you can just go right back over that same wire and put in additional devices.
Yep.
And
Yeah.
without the
So
recrossing these is a real pain.
I agree. So I was pretty happy, except I couldn't get her off the ventilator. So even with just that 12 millimeter balloon, she was shunting right to left to the point that we could not get her off the ventilator in the room. So I closed the ASD, and her oxygenation went right up. She came right off the vent.
Wow.
So that's pretty good. She did great and then the next day she looked awesome. She wanted to go home. We had placed her right back on anticoagulation, as we typically would do with any valve and ring or valve and valve. And then got her echo the next day just to let her go home. And now we have this. So she has a large thrombus hanging off the bottom of the Sapien valve.
Was it in the area of the PVL?
Pardon me?
Was it in the area of the PVL or AVP2?
No, it's the opposite side.
Oh, that's unfortunate.
And that's not part of the anterior mitral leaflet, right?
No.
I mean, it's too bright, but yeah.
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 Okay. Now, Philippe, what would your strategy be at this point in time? Or do you want some choices?
Yeah, I think we're running out of time. But well, on what side? This is in the ventricle, right?
Yeah, it's in the ventricle off the bottom of that mitral valve, of the Sapien valve.
Obviously, the aspiration would be great. But I think this,
Philippe Penumbra, Angiovac.
yeah,
Or-
I think, I mean, if you can recross, Angiovac is no go to here.
Yeah.
Just need to see which way we can go, the easiest
Yeah.
way to go. If you can go,
I was actually just going to ask you, when you close that septum, Steve, did you use a device that would allow you to recross? So
Yeah. She has lots of real estate in her septum. I wasn't really worried about that.
yeah.
I used an ASO occluder
Yeah.
I think a 12 millimeter or a 10 millimeter ASO occluder that she has plenty of room to recross. Would you go after this transeptally through the valve, or would you go through the aortic valve?
So it's a good question, because if you go transeptal, you have to pull it back across a sapien, which obviously is closing with every heartbeat. And if you don't have it in a Ono basket or something, you could easily lose it. So, I mean, I would tend to favor going antegrade and putting an AlphaVac in there. It's a small suction catheter. It's pretty easy to get in there, and then you don't have to worry about pulling it through the sapien and just sucking it right into the AlphaVac. That's how I would do it.
Antegrade, you mean retrograde through the aortic valve, or antegrade through
No, sorry, antegrade through the mitral valve. So I
Yeah.
go through the mitral valve with the AlphaVac, and not try to pull the thrombus through the
Yeah.
valve, but pull it
Yeah.
right into the catheter.
Yeah.
But it's a pretty big one. I know, Jamie, you're the Ono basket expert. I mean, that might be another alternative.
Yeah. I
Think it would cheese or garlic press if you put
Yeah,
it.
it's just it is a relatively cumbersome basket. It's been used to pull Watchman out of the left ventricle before, and that is a thing. But this one, I agree that a snare or an aspiration catheter, if done, I mean, I think the septal closure is not a big deal. It's one day, you just pull it out. I mean, I would just snare it and take it out and go right back through that same hole.
Oh, that's
Uh,
interesting.
and
Yeah.
then I mean, I close all my any septum that I balloon, I close. Because they all have all have crappy RVs in the end, these people, in some way or another. But um I don't know. I'm not sure where. I guess I don't have a great sense of where it is in relative to the outflow track. You also, keep getting distracted by whatever is at the bottom of the screen that looks like it's kind of bouncing around. I don't know if that's shadow or what that is.
I think it's a shadow. I don't think that's anything important.
Okay.
Yeah, it looks like it's a shadow from above.
Yeah.
The thrombus.
Yeah.
All right.
Well, that's peculiar. What did you do?
She wouldn't let me do anything.
Okay.
So I put her on anticoagulation. She's been doing fine. This is about week 2 now. And
What?
no
Really?
neurologic events. So I'm just going to bring her back and reimage her. If it's still there, then I would try to talk her
Yeah.
into letting me get it again.
I will have put embolic protection. I will have
Yeah.
go conceptual.
Yeah.
But
That's what we offer to her.
okay.
Yeah.
Yeah,
Yeah.
the other option could be low dose TPA, so 25 milligrams over 24 hours.
Yeah. Do you think that would embolize it or dissolve it?
It's what we've done for left-sided valve thromboses, like pretty bad thromboses. Yeah, I think your question is about, because this is so mobile, does that make a difference? I mean, I think we've done it with mobile thrombi before, but this one, it does make me just the little stock that's holding that thing makes me nervous. So
bright, isn't it?
Yeah. Well, I'll get a follow-up echo and see what it looks like here soon. So, but
the scary thing is, if it's gone, you just wonder, where did it go?
long as it didn't go north, I'm a little happier. Not perfectly happy, but more happy.
Oh, so why do you think this happened? Do you think this was from the cautery, from the lampoon?
I have no idea. I can't honestly tell you that, Paul. The location looks at the base of the sapien valve. There was nothing that we saw during the case. Went back through all the echoes. There's nothing that was unusual. She was back on. Because we only used a venous access. Well, we did use an arterial access, but closed it, and we put her right back on anticoagulation. I was really stunned to see this.
Was this where you burn though? I'm just curious. Is this on the anterior side, right?
Yeah. Yeah,
Yeah, so there's, did you have just a single burn? Or did
single
you have-
burn, single
Yeah,
burn.
so the risk of that causing thrombus is so low.
Yeah.
But I guess it's not unheard of, but it'd be so low.
Yeah.
Well, that's
It
why I
shows-
was kind of wondering if it could be why it's so bright, and is it part of a flail leaflet
Mhm.
and not clot? Is that possible that it's like a flail aspect to the leaflet?
Well, if it was, we didn't see it in the case, you know?
Yeah.
Yeah,
I mean,
I think you would have seen this on the T for sure.
yeah,
Yeah.
definitely.
I mean, I guess if it's like bunched up behind the valve and then it kind of comes free a little. I have had a flail aortic leaflet before after a basilica that I was like, wow, that really didn't do much. And then on the surface echo the next day, it was like up over the STJ.
Oh, really? Wow.
Yeah.
Well, there's your answer, Steve. That's how you know you actually cut something.
Yeah. I'll get
No,
I'll
I mean,
get follow. Yeah. So
a CT might tell you something too, actually.
Yeah.
If she can handle the contrast.
yeah.
Well,
So
we probably should close up because we're past
Yeah.
the hour. But I mean, you might have to. Well, maybe it's CVI, Steve. You're just gonna have to give us follow up on
Yeah,
this.
I will. Okay.
But I want to thank all my presenters. Wonderful cases, wonderful interaction. I hope you all enjoyed this. Please join us in Denver in July. We look forward to having you, and get us in touch with us if there's anything we can do for you. So have a good night, everyone.
Thank you.
Hey, guys.
Thank you.